Good afternoon, and thank you very much to the National Academies for inviting me. So I'm going to be speaking to you about neuromodulation and non-pharmacologic approaches to pain. These are my disclosures. So why tackle this concept? Well, one is just to highlight an area that doesn't get a lot of attention. Even today, where we talked about non-pharmacologic treatments, device hasn't really been mentioned except for in a comment. It's not something we think about as going along with non-pharmacologic classes of treatments, but maybe it should be. For some of our patients, they don't have options to pharmaceuticals, so we need to look at all the options they do have available to them. As we've seen, there is evidence that supports non-pharmacologic treatment today, of what we typically think of it, and there is a favorable risk-benefit ratio. And many times, non-pharmacologic treatments are going to have fewer complications than pharmaceutical options. And of course, with the opioid epidemic, there's greater interest in this treatment track. So I'm not going to go over all of the prior non-pharmacologic treatments that we've heard about. So I'll go directly into neuromodulation devices, which is a non-pharmaceutical treatment. So neuromodulation is the alteration of nerve activity through targeted delivery of a stimulus to a specific neurologic site. We've heard a great deal today about how chronic pain really is centered within the nervous system, or at least mostly centered within the nervous system. So we need a treatment that can alter the nervous system. We don't need to alter the periphery. It doesn't require more procedures aimed at the periphery. And neuromodulation has the ability to modulate abnormal pathways that have been affected by disease or injury. So the stimulus could be of different types. It could be electrical current, which is what we're going to discuss today. But I'll point out that it could be chemical. There are chemical approaches to this. And then the application has many different possibilities. It could be non-invasive, where the treatment is outside the body, but it could also be an invasive treatment that requires a surgical procedure to use. And the goal, of course, of neuromodulation devices is therapeutic pain reduction and to improve function and quality of life. So since they haven't been mentioned, I'll go through them. Spinal cord stimulation is one of the more commonly utilized methods for pain control with neuromodulation. Within this, an electrode is placed within the spinal canal in close proximity to the spinal cord. Electrical current is delivered, which creates a paresthesia in the area of pain, which reduces pain. That's connected to an implantable pulse generator, all contained within the body, so it requires a surgical procedure to receive. Dorsal root ganglion stimulation is a newer form in which the electrode is placed right near the dorsal root ganglion. This allows a more precise location for delivering paresthesias and reducing pain. Peripheral nerve stimulation has multiple techniques. It could be a sensory stimulation or a motor stimulation. In the picture you see here, it is for sensory stimulation of the occipital nerves. The electrodes are placed with an incision underneath the skin to stimulate the occipital nerves to reduce chronic headache pain. The leads are connected to an implantable pulse generator, so this is completely contained within the body. But there are newer, less invasive options as well. One is the placement of an electrode near a nerve underneath the skin with a minimally invasive procedure, in which the power source and then the control module are both outside the body. There's also a temporary procedure. So an electrode can be placed through the skin near a nerve, connected to an external stimulator to be used for up to 60 days. So a short-term treatment can create a long-term outcome. Brain stimulation is something that's commonly studied and used. There are non-invasive techniques such as transcranial direct current stimulation, that's what's shown in the picture, in which electrodes are placed on the scalp. Current flows between those two electrodes and can stimulate the brain tissue underneath. There's also transcranial magnetic stimulation. So a coil outside the skull can create a magnetic field that creates a current within the brain tissue and thus can provide a stimulatory effect to the brain tissue underneath. On the more invasive end of things, deep brain stimulation requires neurosurgery to implant an electrode within the brain tissue. The trade-off of this is a more precise placement of that electrode so it can be either at or near neural networks that are involved in chronic pain. So there is some evidence for these treatments already. So I gathered evidence from meta-analyses and systematic reviews. I didn't go over individual randomized controlled trials, and I only stuck with those that have evidence. I'm not going over everything that doesn't appear to work. When it comes to migraine, there is evidence that transcranial direct current stimulation and peripheral nerve stimulation are both better than sham controls. For phantom limb pain, neuropathic pain, and spinal cord injury, and various chronic pain states, there is evidence for non-invasive transcranial stimulation. The reason these are so well represented within the studies is likely because they're non-invasive, they're relatively inexpensive, and thus easy to recruit subjects compared to other treatments that are more invasive with greater chances of complication. For a failed back surgery syndrome, spinal cord stimulation does have some evidence compared to various other treatments. So what should we use? We have various non-pharmacologic treatments. We have a neuromodulating device treatment. I would say if you look at the evidence, we know that none of these is going to be the right one to choose. As was just mentioned, that they all have modest or small effects. So maybe there's a better way. A different approach would be a multimodal treatment pattern, which we've heard about. So within the treatment of pain, a multimodal intervention is using different mechanisms or different interventions that have different mechanisms of action aimed at different pain mechanisms. So we have a hypothesis. We don't know if this is true. Let's say non-pharmacologic treatments such as exercise and neuromodulation reduce pain in different ways. If we were to take an example of knee osteoarthritis, we could prescribe exercise, which will improve biomechanics at the knee, thus reducing pain with use. It can alter endogenous pain mechanisms, which reduces pain, may contribute to neuroplasticity to reduce pain long term. We could also use transcranial direct current stimulation. So there's evidence that it improves somatosensory function and can be pain relieving in and of itself. And it also can stimulate the cortex of the brain to help encourage long-term pain reduction. Now at this point, we don't know that this is happening, but this is at least the theory of using them together. So the effects may be summative. You get the effect of the stimulation, the effect of exercise, and you can just add them together. But the hope is that some of these treatments can be combined in such a way that the overall treatment effect is even greater, that there really is a synergy. But again, that's something that we don't yet know. So there's little evidence to guide how to use these in practice at this point. So I found 3 randomized controlled trials I can show you. So the first is for complex regional pain syndrome, in which spinal cord stimulation, in the addition to physical therapy, was more effective than physical therapy alone. So this is one randomized controlled trial which they followed patients for many years, and they found that out to 2 years this was effective. For fibromyalgia, transcranial direct current stimulation plus aerobic exercise was better than either alone. One randomized controlled trial for chronic low back pain found that transcranial direct current stimulation and exercise is better than exercise and sham stimulation. But this is the limit of the trials that I was able to find to show you what is the evidence for multimodal treatment. But this is how we're approaching it in our lab. So we have developed a treatment for hemiplegic shoulder pain or shoulder pain after stroke, which is common and can be difficult to treat. The treatment is peripheral nerve stimulation, which has level 1B evidence. With this treatment, we place an electrode between the middle and posterior deltoids of the affected shoulder, attach that to an external stimulator. That stimulator uses electrical current to create muscle contraction every 30 seconds for 6 hours a day for 3 weeks. Subjects take this home. They're able to perform this treatment at home. At the end of the treatment period, they come back and we remove the electrode. The comparison treatment was another active treatment, so physical therapy in this case. So this was 8 hours of therapy over 4 weeks. It was an evidence-based protocol of therapy with an educational component on proper positioning and handling of the limb. There was exercise to improve range of motion and strength, as well as task-specific therapy to improve function. As with all exercise therapy programs, the subjects were advised to perform a home exercise program during the treatment period of 4 weeks, but also during the follow-up. So these were the results of our study. Our primary outcome, which was the worst pain in the last week on a 0 to 10 scale. We recruited 13 subjects to peripheral nerve stimulation, which is the solid line, compared to 12 in physical therapy. So we can see within the 4-week treatment period, both groups had a reduction in their worst pain in the last week, which we would expect. Both groups received an active treatment. As we entered the follow-up period, again, both groups had a reduction in pain compared to where they started. The peripheral nerve stimulation was a greater effect, but both groups had improved. So we could have stopped here and said, well, we've answered our question. The question was, how does peripheral nerve stimulation compare to physical therapy? But that's not our real goal. Our real goal is, how can we help our patients with hemiplegic shoulder pain? So the next obvious question is, well, what if we add these? And so we're currently in the middle of a multi-site randomized controlled trial to answer this very question. So we're recruiting 96 subjects with chronic hemiplegic shoulder pain. One group is getting the multimodal treatment. One group's going to get peripheral nerve stimulation and sham physical therapy, and the other one's going to get sham stimulation and physical therapy. So this will be a blinded trial about who is getting what. The subjects in the trial won't know. And this will allow us to answer, what is the efficacy of a multimodal treatment and the incremental effects of the others? We're also adding other important outcomes. So mechanisms, so that we can understand, how do each of these work? Is it really that physical therapy is working on biomechanics and that peripheral nerve stimulation can alter the somatosensory system? And then we're also examining patient selection variables. Is it things such as catastrophizing or fear avoidance that's making a difference? Is it their anatomic abnormalities based on imaging? These we don't know, but these are important things that need to be included in trials of multimodal treatment. Our expectation is that the multimodal treatment will be better than either alone. Another example out of Boston from Spalding is multimodal treatment for phantom limb pain. So this is comparing mirror therapy for phantom limb pain with transcranial direct current stimulation. So again, they're recruiting subjects with chronic limb pain. One group gets the multimodal treatment. One gets the transcranial direct current stimulation and a sham mirror therapy treatment. The next gets a sham stimulatory treatment and mirror therapy. And this trial is including a double sham. So they'll be able to really look at, well, what is this multimodal treatment and the others compared to placebo, as well as what's the incremental value of adding them together. Again, they're also looking at mechanisms. We need to know mechanisms to figure out how to improve this in the future, how we're going to combine different treatments together to get the greatest effect. So there are ongoing trials with multimodal research now. These are ones that are easily found. Our group is starting a trial for physical therapy and peripheral nerve stimulation for subacromial impingement syndrome, but then there's also ongoing for sensory motor retraining and transcranial direct current stimulation for chronic low back pain, as well as transcranial direct current stimulation exercises for knee arthritis. So we're at the very beginning of trying to learn more about multimodal treatment. But we should know more in the future, and this is important to get to studies where we're looking at cost effectiveness or pragmatic trials, but we need to know how to combine them in the first place. Thank you.